There we go. Welcome to the webinar, Telehealth Communication Tips. I'm Barbara Lewis. Thank you for joining us. This webinar is going to last about 30 minutes, and if you have any questions, you can type them in the Q&A box, and we'll try to get to them during the webinar or perhaps Q&A afterwards. But if we don't have a chance to get to your question during the webinar, we will respond afterwards. But before we get started, let me briefly talk about DocCom. DocCom is a proven online interactive healthcare communication skills learning system. We have 42 multimedia interactive online modules with over 400 realistic videos, some of which are annotated. The authors are leading faculty, and we have a learning management system for faculty on the back end. DocCom has subscribers all over the world. As a matter of fact, we have been translated into 3 languages. We've had over 100,000 subscribers over the years, and about 90 institutions subscribe to DocCom. We have 10 journal articles that support DocCom. And a sister platform of DocCom is professional formation, and we have 12 modules for learners and 2 faculty development modules on faculty development and remediation. And those are free during COVID. And at the end, I'm going to talk to you about how you can get a trial subscription to DocCom and get these modules free as well. But let's get started, and let me introduce our presenters. Joining us today is Shmuel Reis. He is a family physician in Northern Israel and faculty at the Holon Institute of Technology. He is also a DocCom module author. And with him today is Dr. Refael Barkan. He is Vice President for Innovation, Entrepreneurship, and Internationalization at the Holon Institute of Technology. So welcome.
Thank you.
Thank you, and welcome, dear participants. We can't see you right now, but I hope you're all there. Can you bring up the presentation, Rafi?
Yes,
Thank you.
just a minute.
Thank you, Barbara, for the invitation. It's a real honor and pleasure for us to be here today with you and the attendees. And as announced, we are going to talk to you about telehealth. And of course, we would like to start by quoting Churchill. 82 years ago. Never let a good crisis go to waste. Next slide, please, Rafi. It seems that I cannot move them. Okay.
You want to bring them up to full screen?
Okay, thank you. In the next slide, I'm actually quoting the New England Journal of Medicine, analyzing the COVID crisis and its relationship to digital technologies. Let's wait another minute. Hopefully it will come up.
Just a minute. I have a problem. Do you see the screen?
I can see the screen, but we are still in the first slide.
Just a minute again.
And it's not presentation mode.
Second slide.
And now?
I can see the first slide on.
Again. Just a minute. Sorry.
Okay, so in the New England Journal of Medicine, just 3 months down the road from the beginning of the COVID pandemic, this paper was published that said that it seems clear that we need US healthcare an immediate digital revolution to face this crisis. because the healthcare industry in the US is structured on the historically necessary model of in-person interactions. Workflows and incentives have been developed to support and reinforce a face-to-face model of care, resulting in what you all know, a congregation of patients in emergency departments and waiting areas. And this care structure, as the author states, contributes to the spread of the virus to uninfected patients who are seeking evaluation. Next, please. She goes on to describe what such a digital revolution can be consisted of.
You see it?
We are still stuck in the second slide.
Okay, so I will go out of the.
Okay.
Let's see this.
So I will. Oh, here it is. So of course, video visits. This is what we are talking about today. But there are so many other telehealth modalities: text, email, mobile phone applications. Now we have also wearable devices and chatbots, which are explained in the second paragraph, that all could be deployed for synchronous or asynchronous support, both for the COVID-19 patients, but also for routine clinical services. Hopefully, COVID will be leaving us soon. And in post-COVID, all over the world, we are certain that business will not be as usual, and that some of the telehealth digital revolutions that happened will persist. Next, please. In our little corner in Israel, we were faced with the same problematics. And here is a paper that was published recently describing the largest HMO in Israel called Clalit, tackling of the crisis. And you can see that it was done by shifting physical services into the community, the patient's home, and the virtual domain. More than 90% of Clalit COVID patients in the first wave, now we are in the fifth, by the way, were taken care of in their homes according to a structured care and monitoring protocol that included installation of temperature and saturation measuring instruments in the patient's home, as well as routine contact and monitoring by providers in the community. There was a major ramp up of home care services, such as delivery of drugs and visits by medical teams to home, also for carrying out blood tests and home visits. The shift into the community, into the patient's home, contributed to the wise use of the system's resources, such as that medical services were provided in a location in a way that suited each patient and without overburdening the system. Next, please. In parallel, there was a shift of services into the virtual domain. Rapid assimilation of monitoring capabilities in patients' home and telemedicine encounters, mostly by the means of the telephone, smartphone, in this case. During the first lockdown, 50% of all primary medical encounters in the community were of this type and did not involve any physical contact between caregiver and the patient. The technological capabilities were required, and medical staff gained extensive experience in using them, and at the same time, they acquired the skills to provide care under these unique constraints. Next, please. So back to the US, Katrin Sinsky, that you probably all know about, states that the common narrative is that while Corona happened, payment and policy barriers were quickly lowered, and voila, telemedicine became, in a matter of months, widespread and successful fait accompli. And during this time, telemedicine arrived with a bang and is thankfully here to stay in the US. Yet it will still take time to understand the risks and benefits, the appropriate patients for in-person versus virtual care, and the development of optimal models of teamwork for this platform. And she concludes by summoning us not to repeat the mistakes encountered when EHR implementations were anticipated through rose-colored glasses, but rather look with clear eyes to the lessons from the past generation's technology challenges. Another American study showed, next one, yeah, that virtual visits spiked from 1.6% in 2019 to 70.6 in the second quarter of 2020. This is in Canada. Similar results were reported also in the US, and one study says that telehealth utilization was 78 times higher in April of 2020 compared to February of the same year. And they also highlighted that although telehealth services have stabilized since the beginning of the pandemic, it has done so at level 38% higher than before. And a year ago, the authors say that there is a differential uptake of telehealth depending on the specialty, with the highest penetration in psychiatry, substance use treatment, followed by endocrinology, rheumatology, and gastroenterology. So I think we have done enough to set the stage. And here we want to poll you, our dear audience, and ask you these 6 questions about your current practices. Do you use electronic records? Do you communicate via email, etc.? Please answer the poll. We'll give you a minute or two, and then we'll see what are your digital practices right now. Thank you. The first one is in. Thank you very much, sir or madam, and I hope you set an example. Picking up nicely. Thank you. Okay. We will share the results now. So for the first question, 10 out of 12 are using electronic records. For the second, 9 out of 12 communicate by email. Third question, telemedicine, 8 out of 12. Social media, 6, half of you. For personal purposes, and a minority, just a quarter, for professional purposes. Microblogging, nobody. And finally, professionally, nobody. So I think this is probably not completely representative, but is a picture of the way things are in the United States. And Rafi, I don't know if you will agree, if you would have showed this to an Israeli audience, I think the numbers would be much higher, except probably for the blogging. People will universally use records, electronic records, communicate by email, use telemedicine, and then the participation in social media and microblogging will be less unanimous. So there is what you look for in making America more digital. Next. Your turn, Rafi.
Okay, since I'm half a mathematician and a computer scientist, I like definitions. So let's talk a few minutes about telemedicine components. What is teleclinics, telemonitoring, teleinformation, and teleeducation? Well, teleclinics includes clinical consultations and at the same time a remote care. We see it patient-doctor interaction by virtual visits, but also doctor-doctor online consultations. Telemonitoring, we mean that it is clinical information collected for the purpose of deciding regarding the patient's clinical decisions, meaning vital signs, blood pressure, oxygen saturation, ECG, and etc. Teleinformation, by that we mean sharing or providing or providing accessibility to medical information. It can be via websites, online forums, videos, WhatsApp groups, and so on. And of course, teleeducation, quite traditional online courses, workshop, lectures to healthcare professionals, but to patients and their families as well. Key challenges regarding the promotion of telemedicine, we can name these four. First of all, the increasing of life expectancy worldwide. The second is the increasing of prevalence of chronic diseases, including comorbidity and multimorbidity, that causes or actually calls for ongoing medical treatment and follow-up, and the necessity for quick, swift, available clinical response for populations with growing clinical needs, including in rural areas. In Israel, it exists, but it's more abundant elsewhere. And the last COVID-19 effect, the need for physical distancing that actually calls for more promotion of telemedicine. I would like to give you two examples of telemedicine that actually were created in Israel. One was a few years before the COVID-19 pandemic. It is the MoMA call center. It was generated by the second largest HMO in Israel, Maccabi Health Services. And it's a center that was located at Sheba Hospital, the biggest hospital, the largest hospital in Israel. And the aim was treating comorbid and multimorbid patients, various diseases. I hope we can see the video. Do you see it?
Maccabi Health.
Can you see it?
This is the slide.
Just a minute. Okay. Again, the problem with.
We probably have time to see only one of the.
Okay.
Services presents a revolution in the concept of chronic disease management with the establishment of a unique treatment center that provides ongoing care for patients in wide geographical areas. Developed in collaboration with the Gertner Institute, the program combines advanced technologies with a novel therapeutic approach based around an online multidisciplinary treatment center, the first of its kind for managing chronic diseases. The treatment center was designated to provide care to 10,000 patients suffering from various illnesses, including patients needing all-day attention and those who have difficulty getting to checkups at a doctor's office. The idea of the center is to provide a support network for both patients and the family physician to improve and enhance patient medical care. Monitoring is performed by 150 staff members, including nurses, specialists, social workers, dietitians, and a clinical pharmacist. The medical staff assesses a patient's condition and, if necessary, refers them for treatment to one of the community service centers, clinics, daycare centers, and emergency medical centers. Treatment and follow-up by the center staff gives patients self-care management tools, enabling intelligent use of community services and hospitals. The treatment process is carried out with the full cooperation and coordination of the family physician. Patient monitoring is performed using various technologies, such as phone calls or video calls. Please screw the needle onto the syringe, and this growing relationship between nurse and patient allows better assessment of the patient's condition. Please place the cuff on your arm above the elbow. The fact that I can see the nurse makes a big difference. On one hand, it's good for my heart to see pretty girls. On the other hand, getting a response is comforting and most important. There on the side, a green button, you see? Convenient video solutions will solve many problems of accessibility and availability. It makes me feel good to know that someone can see me in my situation and give me the right treatment to help me at that moment. The center's activities are based on an advanced health information technology management system, which includes unified medical records that are viewable by all therapists, a clinical decision support system for managing complex medical conditions, and a patient management database. My main advantage as a physician who works with the MoMA Center is that it actually lowers the amount of patient visits. It also lowers the amount of hospitalizations and improves the personal treatment of my patients, especially those aged 70 through 90. Part of the nurse's activity is conducted with advanced technologies. Hello, this is Sarah from the Multidisciplinary Treatment Center of Maccabi Health Services. I am a virtual nurse and I can understand human language. The establishment of the Multidisciplinary Treatment Center is a revolutionary change in community-wide chronic patient care and allows better integration of the various medical treatments given to patients. Maccabi Healthcare Services, taking you forward.
Okay, and this was, as I mentioned, done I think, Shmuel, correct me if I'm wrong, 4 to 5 years prior to the COVID-19 pandemic. I will jump over Title Care, which was actually flourished during the COVID-19 pandemic. It's an Israeli startup that was quite successful in providing instruments for home care, actually providing patients and their family with the possibility of checking themselves and transmit and transfer the results to the physician, to the nurses, or to a remote center that can assess and diagnose and help them actually manage their condition. Very successful company. I think all of the Israeli HMOs acquired or actually got the license to acquire this instrument and actually provide them by some amount of money to their insurers, their patients. I want to talk a bit about the key barriers to promoting telemedicine. Of course, lack of organized mechanism for budgeting and strategic management It is always one of the main barriers, and it is, especially if it is at a national level. Cultural differences, we see that in different populations, adapting to changes. I'm talking about old people versus young people, but also religious versus secular and other minorities. And that connects also on that also leads to difficulties in digital literacy, adoption of new technologies, technical problems, though we have that quite rare, it's not so often, but still transferring medical data in electronic systems is prone to errors due to poor infrastructure. Lack of resources for training healthcare professionals, whether they are physicians, nurses, physiotherapists, and so on in telemedicine. They actually don't learn it, or they don't learn it enough during their higher education. Legal, ethical, and regulatory issues are also barriers. They all the time accompanying the change in the nature of care delivery from face-to-face to virtual.
Rafi, we have 3 minutes left.
Okay, I won't talk about regulation of telemedicine in Israel. I just say that we have circulars from the Israeli Ministry of Health, and during the COVID-19, we had also some paper that was published by it. Concerns of healthcare professionals: incorrect diagnosis, relationship with patient may be impaired because of the technology, data security and privacy, inequality, we talked about it, different socioeconomic populations, high expectations from the healthcare professional, and budgeting, the compensation issue. There are telenurses, virtual nurses, we saw that, and I'm jumping to the advantages. It's fast, good, and equal. It improves treatment, it makes it more efficient, it promotes coordination and collaboration among various healthcare professionals, it creates actually the feeling of, or the sense of a team that works together, and it responds to urgent consultation in real time. The disadvantages, of course, fear from the unknown, potential to harm the trust and intimacy between patient and physician, unavailability around the clock, it causes patients to expect more. Of course, technology can't fully replace the unmediated encounter between the doctor and the patient. Patient overuse, sometimes it causes patients to refer to the physician as the administrative helper or assistant, security and privacy hazards.
Okay, since we have only 1 minute left, can you move to the, skip this slide, the one afterwards, and this one as well, and we'll get to the 2 last slides. The next one, please. As technology extends and replaces elements of contemporary medicine, we have to remember that the patients' and physicians' roles will be defined by the human elements of medicine that cannot be automated. This is a picture of myself doing a house call, actually on an ex-American that came to Israel 2 years before this visit from New York. And I found myself in the presence of 4 generations. The patient, her daughter, her granddaughter, and a tiny grandson. And of course, this cannot be replaced by telemedicine. And the last slide, please, is actually an invitation for all of you With Brown University, we are going to have the third patient practitioner and computer conference in October of 22 in Providence, Rhode Island, and you are all invited. The conference is about holding on to the core of our healing professions in a time of technological change. And it's the third one. The first one was done in 2017. The second was done virtually 6 months ago, and the third will be at the end of this year. Thank you very much. Barbara, can we take a few questions for those who are?
We actually don't have any questions, and we're coming up on our time. But that last one that you were just showing, that last slide, that is on the left was such an iconic picture that a child drew with the physician facing the computer and the back to the child. And
right, this was published in 2012 in JAMA in the Peace of My Mind section, and it's a picture that a 9-year-old patient took when he visited his pediatrician, and you can see that the physician is glued to the screen with his back to the family and patient, and it is contrasted with the 150 years prior picture of a doctor's vigil for a full night for a dying child.
right, artwork is worth 10,000 words, right?
Exactly.
Well, thank you very much to our presenters.
Thank you very much.
Dr. Reis and Dr. Barkan, and to everyone who joined us today. The recording and the PowerPoint will be on DocCom YouTube channel shortly. And please contact me if you'd like a trial subscription to DocCom, no credit card is necessary, or if you'd like a free subscription to Professional Formation. Thank you very much.
Thank you.